Welcome, everyone. Thank you so much for taking the time to be here this evening. I'm Dr. Rutika Mehta, and I'm an associate member in the Department of Gastrointestinal Oncology here at Moffitt. I'm excited to introduce you my colleagues in just a moment, and I'm confident you will find value in the information we'll share with you tonight. But before we begin, please be advised the content is not intended to be medical advice, and the viewer should consult their physician should they have any questions. The viewer should not rely on information contained in this presentation for immediate or urgent medical needs. Additionally, if you think you may have a medical emergency, call your physician, go to the nearest emergency room, or call 911 immediately. Never disregard professional medical advice or delay seeking care because of information contained in this presentation. Again, we're so pleased to have you with us tonight. Before I introduce them, I want to remind you that after we hear from our speakers, you will have the opportunity to have your questions answered by the experts. We invite you to type your questions into the Q&A box located at the bottom of your screen. Now, moving on, let me introduce to you Dr. Pimiento. Dr. Pimiento is an associate member in the Department of Gastrointestinal Oncology. He's a surgical oncologist by training and has helped develop a comprehensive robotic program for the management of upper gastrointestinal and pancreatic tumors here at Moffitt, making it one of the leaders in the country. He also serves as a member for the NCCN Guidelines for esophageal and gastric cancers. So Dr. Pimiento, please take it away.
Hello, and thank you, Dr. Mehta, for those kind words and introduction. And I'm happy to see you all. I'm from Boston, so if you get any changes in my accent, it's because I have a Boston accent today. I wanted to start by showing you what could look the usual oncologic life of a patient that has a diagnosis of cancer. This is not true for everybody. This is not going to be quite accurate for everybody, but kind of goes through the highlights of what could happen to a patient that has an oncologic diagnosis. And we could call that the oncologic care pattern or the way they are going to receive treatment. So as you see, we have in this initial circle in the inside, patients that are considered to be high risk, then they get diagnosed with cancer. You see that they get treatment, they may get surgery or definitive therapy, they may get adjuvant therapy, they'll go surveillance. In some cases, they may develop metastases. As you see at Moffitt, we're trying to develop clinical trials or research programs across the whole continuum of cancer care. So we have different studies and different projects that we have in each one of these different stages of cancer care. Today, you're going to hear some of these stages, and I try to highlight in bold some of the things that we're going to be talking about. Next slide, please. But specifically, one back, please. Specifically, my role is going to be talking about what happens around the period where patients are receiving neoadjuvant therapy, that means therapy before surgery, and where the patients are receiving surgical therapy. So we're going to be talking about surgery for esophageal cancer and how we can improve the outcomes for esophageal cancer. Next slide, please. So to kind of have, okay. So to kind of get us started, we're going to talk about the treatment for each stages of those cancers. So when we have patients that have early stage cancer, we're talking about most of these patients are going to have cancers that are localized in the esophagus very early on, usually found incidentally. They are having endoscopies for some other reason, and then the cancer is found. In those cases, sometimes you go straight to surgery, and that is manifested by this little knife here, or occasionally we can get lucky enough that the patient will be a candidate to have endoscopic resections. And Dr. Mach is going to talk about this a little more in detail. When the patient has the local regional cancer, those means the cancer are a little thicker. They are now threatening to go past the wall of the esophagus or go into adjacent lymph nodes or have a high risk of involving the adjacent lymph nodes. We're going to be talking about patients receiving neoadjuvant chemotherapy, radiation, and if the patient is fit enough, they have surgery. When we're dealing with patients that have cancer that goes outside of the confines of what we usually can remove with surgery, or what is safe to remove with surgery, then we're talking about cancer spread or metastatic disease. In those cases, most patients are going to go through clinical trials, systemic therapy, as indicated by this little bag here, and they may end up having radiation to try to consolidate and improve their outcomes. So as you can see, the management depends on the stage of the cancer, the place where the cancer is. I'm going to talk a little bit about surgery and how to get in best shape of surgery. And I'm going to flip it a little bit. And initially, I'm going to talk about surgery and why it's important, and then a little bit how to improve the outcomes for patients having surgery for esophageal cancer. Next slide. So it's important to understand that the surgery for esophageal cancer includes removing the tumor, adjacent normal tissue to be sure the whole tumor comes out, and also include removing the lymph nodes where the cancer could be. That operation is called an esophageal gastrectomy, and commonly you're going to hear it mentioned as the gastric pull-up. So what we do in brief is removing the top part of the stomach, as you can see in this slide, and then we are going to be removing also the lymph nodes that are adjacent. So this top part of the stomach, we are going to be removing the lower part of the esophagus, the lymph nodes that are adjacent to it, and then we're going to be lifting the stomach up to be connected somewhere in the neck, and that operation again is called a gastric pull-up. That technique can be done either minimally invasive or can be done open. And open is the old-fashioned technique that you guys know about when we make big incisions to try to remove the lymph nodes, try to get the operation done. So the difference is the size of the incisions and the capacity that we have with some new technology to perform a more precise operation. These operations, as you can see with these numbers, are quite complex and quite involved, with complications that range between 70 to 80%. And although most complications are not severe, about half the patients that have these complications can have what we would consider major complications. That would be, for example, a pneumonia. That would be, for example, a significant infection. Or they can develop something that is called an anastomotic leak. That is that the connection between the esophagus that is cut and the stomach that comes together, it just has a little hole in between it. And that is called an anastomotic leak. Again, due to all this complexity of care, we can see how the 30-day mortality for this operation, and that means the chance that you may not make it more than a month or out of a month of surgery, is about 6%. And this is the reference that I'm using for these numbers. And that tells us, to put in perspective again, that this operation is quite involved. If you were to think about the mortality of an open heart surgery, we'll be talking about 1%. This is about 6 times more complicated. Next slide, please. So to try to improve on this, we have worked for many years at Moffitt Cancer Center in a robotic esophagectomy. And that means using robotic technologies and performing what we better consider telesurgery, or we are controlling the robot ourselves, and we are utilizing this technology to perform the procedure. So it's not that a robot is scheduled and you put the numbers and whatever and the operation is happening, but actually we, the surgeons, are actually performing those procedures. And we start doing this procedure because the chances of patients having complications with this type of procedures were lower. And we published our experience a couple of years back with the first 350 robotic-assisted esophagectomies at Moffitt. And what we could tell is that patients tend to do a lot better, especially they tend to have a much lower length of stay, and that means the time you are after surgery in the hospital. And patients had less chance for reoperations. Other effects like time of surgery or operative time is a little longer for robotic surgery, but that tends to pay off when we're doing it for patients due to the recovery. So this initial experience, next slide. Next slide. Back one, please. This initial experience was complemented by an experience that we just submitted for presentation this year, and it's our first 500 patients over the last 10 years that underwent robotic assisted resection of the esophagus. The patients were with a median age of 66 years of age, and you can see the range, having patients as young as 30 and as elderly as 87. This is important to remember, because if you were to have symptoms of dysphagia or something, even if you're young, it's a good idea to consult with a gastroenterologist. Most of the patients were male, as expected, and the most common histology is adenocarcinoma. This is a cancer that grows from the glands that sit in the lower part of the esophagus, or the junction between the esophagus and the stomach. These patients will receive neoadjuvant therapy. That means therapy given before surgery in the vast majority of patients, with only 16% going straight for surgery. Next slide. And we are able to find about 23 lymph nodes in a median number. That is, most of the patients getting at least 23 lymph nodes removed. The blood loss is somewhere about 200 mLs. That is about a cup of blood. So the blood loss for this operation is about a cup to 2 cups of blood. And the time in surgery is somewhere about 7 hours. If you want to see more details about how these operations look on a video, you can go to our website. This is in YouTube, and it's called the MCC Gastrointestinal Oncology Video Library. And you're going to see not just operations for esophageal, but for gastric, for pancreas. And it's a good resource if you want to get familiarized with what maybe or what we do in the operating room. Next slide. But what is more important is that, as you can see, the outcomes continue to get better. And we can see, especially in the time the patient spends in the hospital, how in our original experience with the first 100 to 200 patients, we were having patients having to stay in the hospital 12, 13 days. And right now, the patients are staying in the hospital somewhere between 7 days, 6 days, 8 days. And that actually is very important, because we believe that patients recover. The sooner we can get them back to life, back to home, they'll do better. Not just that, but it's becoming a safer procedure with a 30-day mortality of about 3% and a 90-day mortality of only 5%. That means that 95% of patients that had this operation are going to be alive and doing well at 3 months after surgery. The median survival, and that means the time that half people are dead and half are alive after surgery, is somewhere around 6 years. That doesn't mean that you will survive 6 years after surgery. It may be a lot longer or shorter, depending on your response to therapy, how therapy went, other comorbidities that could limit your lifespan. And not just that, but we are able to show that the treatment here at Moffitt is quite effective, with a very high chance when you get chemotherapy and radiation that the tumor is completely eliminated. And that happens in about 37% of patients. And this is the breakdown based on histology. So this slide that I have shown you are trying to illustrate how, with the new techniques, new technologies, as robotic surgery has advanced over the years, we can have very good outcomes for patients, and how the patients are having a really good survivals, and how they're surviving for many years. But now we need to figure out how we can make them come to surgery in even better shape to try to improve even better the outcomes. Next slide. So for that, we need to focus on malnutrition. And that is important because most patients that have gastroesophageal tumors are going to manifest some degree of malnutrition. It can be caused by poor appetite, poor intake, cachexia, obstructions, and clearly negative impacts quality of life, treatment tolerance, treatment outcomes, as well as recovery after surgery and overall survival. Next slide. So with this in mind, we have develop a protocol, and this is in combination with one of our behavioral scientists that works in the Moffitt Cancer Care Delivery Lab. And the usual treatment paradigm for these patients that are going to require chemotherapy and radiation before surgery is to have them diagnosed. We do a baseline nutritional assessment. 5-10 weeks later, we do another nutritional assessment, and then patients go for surgery. Next. And then they have nutrition visits as needed in these 5 to 10 weeks. So basically, we're trying to kind of recognize if the patients are having issues. Next slide. But our protocol that we've been conducting over the last year or so, and some patients have been enrolled, is to try to determine if these patients are candidates to be enrolled on an intense evaluation through telemedicine by nutritionists, dietitians, as well as, next slide, through a Fitbit that patients get, and then they can put their data of the information regarding intake in the app, and they can put the activity they're having in the app, so we can have a better understanding of how the patient's physical condition is going through these 5 to 10 weeks of therapy. Next slide. So the goal would be to have a continued nutrition follow-up. And the idea behind this is to early recognize the nutrition needs and the patients at risk for malnutrition to improve their outcomes. Currently, we have enrolled 10 patients on this trial. And if you are a patient of Moffitt, you may be approached to be part of this trial, because our idea is to try to have the patients come into surgery in the best shape they can come, so we can have even better outcomes than what I showed you before, because our goal is to use surgery as a tool to try to provide patients with the best overall outcomes that we can. And that is what I have for you. And again, I'm very happy I was able to talk to you guys today, and thank you for joining us.
Thank you so much for that, Dr. Pimiento. Next, I'd like to introduce to you Dr. Russell Palm. Dr. Palm is an assistant member in the Department of Radiation Oncology. He's a gastrointestinal radiation oncologist and has specific interests in novel radiation techniques for esophageal cancer patients. His research interests include improving patient selection to safely allow for organ preservation through imaging or biological markers that predict for tumor response, and integrating immunotherapy and other radiation sensitizers in the definitive treatment of gastrointestinal cancers. Welcome, Dr. Palm. Please take it away.
Thank you, Dr. Mehta. And thank you for all being here and joining us tonight. And again, my name's Russell Palm, and I'm a radiation oncologist here at Moffett, specializing in GI oncology. And I work very closely with Dr. Sarah Hoff and Dr. Jessica Frakes to care for our patients. Next slide, please. I have two concepts or research interests that I'd like to introduce to the group tonight that we're hoping to translate and to implement precision medicine for our patients here at Moffett. The first concept that you can see here is the Radiosensitivity Index, or RSI, or the second iteration, GARD, which is Genomic Adjusted Radiation Dose. And this is some of our preliminary and novel work here at Moffett, pioneered by Dr. Javier Torres Roca and Stephen Estrich, to kind of further our understanding on individual patient biology regarding their sensitivity to radiation and to improve patient selection. And so just anecdotally, over the past century, radiation has been dosed due to cancer type and cancer response, but not specific to a patient's cancer. And so while we've had multiple randomized clinical trials and collective groups for multiple different types of cancers to help us define a best treated dose for a population, and in general, lymphomas and squamous cell carcinomas tend to be more sensitive to radiation and have a greater pathologic response, and adenocarcinomas and sarcomas tend to be more resistant and require higher doses for treatment. We don't have anything specific for a patient that I can tell a patient in clinic, I know exactly the dose of radiation that may optimize our disease control, but also minimizing your toxicity. And this is one of our first pioneering efforts to kind of further our understanding of that. And the radiosensitivity index in the bottom left that you can see is a 10 gene signature derived from cancer cell lines that's been correlated with patient outcomes. And on the right is a figure from Jake Scott, who's another Moffett trainee that currently works at the Cleveland Clinic. In his publication in Lancet in 2021, he described the genomic adjusted radiation dose. And you can see populations of patients and outcomes at a few different dose levels, 50 gray, 60 gray, and 70 gray, correlating with the doses that we deliver for breast cancer, gliomas, which are brain cancers, as well as head and neck squamous cell carcinomas. And what you can see is while the dose is consistent, the genomic adjusted radiation dose, which in essence is the patient response or the clinical outcome, can actually be quite heterogeneous across that group at that dose level, but between patients. Next slide, please. So what that means in the implication of the data that we currently have, which is all retrospective, and on the left, this is a cancer cell line, as well as the preclinical data for the radiosensitivity index. We've actually been able to predict patient responses when we've retrospectively analyzed patient RSI, and at the top, looking at non-responders and responders for GI cancers, specifically esophageal and rectal cancer. And this may have direct patient implications. As you can see, for a low-lying rectal cancer patient or an anal cancer patient, they may be at risk of having a permanent colostomy, where when they have a very radio-resistant tumor, and we are unable to know that, The dose of radiation may be suboptimal where we aren't able to treat to that level, or it may require a dose of radiation that we can give safely that is higher, but we just don't know for that specific patient what dose should be delivered. On the bottom is also verification of this genetic signature in head and neck cancer patients, demonstrating a nearly 20% improvement in local regional recurrence for patients that have a radiosensitivity derived by this index. And this may prevent patients from needing highly morbid salvage procedures, as head and neck cancer is commonly a disease cured by chemoradiation. Next slide, please. So the opportunities that we currently hear at Moffitt for GI cancer for radiosensitivity index is twofold. One, we're actively actually accruing to a clinical trial named 2911 here. And a lot of this is due to our current investment in technology here at Moffitt. And on the right here, you can see the Meridian platform, which is from a company called ViewRay, which is a hybrid MRI and linear accelerator combinated machine. In essence, that it is able to obtain MRI images and diffusion weighted images and track tumor while we're delivering treatment every day. And so we're able to actually image while radiation is being delivered, improving our ability to understand cancer biology during a course of radiation treatment. So we've been able to obtain funding to collect RSI in this trial for rectal cancer, but as you can imagine, rectal cancer behaves differently from anal cancer and also behaves differently from esophageal cancer. And furthermore, esophageal cancer is characterized by two different histologies, squamous cell carcinomas, which, as Dr. Pimiento noted, tends to have a much higher pathologic response rate than adenocarcinomas. But there's another benefit from the MRI LINAC in that while we can track the tumor, we can reduce the treatment margins that are required. And so the trial that we're currently proposing is going to look at treating patients with this machine and seeing if we can minimize toxicity for definitively treated patients, but also patients that can go to surgery by minimizing the treatment margins and minimizing radiation dose to the heart and to the lungs. But in the future, what we would like to do is collect radiosensitivity index features from these patients to see what patients may be able to be cured with chemotherapy and radiation, and may be able to safely be observed by endoscopy and by imaging after chemoradiation if we know that they have a high likelihood of having an excellent response. A future goal would be can we collect data on multiple GI patients under an umbrella GI protocol for patients that may be able to be cured by chemotherapy and radiation, but that's a secondary objective, obviously, from this talk today. So that's in essence the first concept is how can we more consistently be able to collect this for our patients and improve this through our esophageal cancer treatment on this MRI LINAC. Next slide, please. So the second concept I wanted to speak on today is pivoting, is that while we're looking to advance our understanding of patient biology, there's actually a lot that we can do in terms of improving our techniques. And I think histotripsy, which has been mentioned in my clinic a few different times, is kind of a novel area that we're looking to advance in a partnership with Moffitt. And this is pioneered by a group called Histosonics, which is headquartered in Minneapolis. But as you can see on the right, and I hope we can replay the video, this is an ultrasound-based platform which uses acoustic cavitation, which is in essence just synchronizing the frequency of ultrasounds to form a cavitation site, which is here, and it's about usually about 2 to 3 millimeters in size. And what this results in is a rapid gaseous expansion and contraction, which ruptures cell membranes. And on the bottom left, what you can see here is a prostate of a dog, showing an ablation zone in the right lobe of the prostate, but also in a human patient that's been trialed, where you can see actually a large cavitation zone in the left lobe of the liver. And what's interesting about this technology, which separates it from other ablative techniques, is that there's an actual therapeutic index between liquefying tissue versus blood vessel, which you can see coursing through the left lobe of the liver. So blood vessels, nerves, bile ducts have a higher level of structure on the walls of those entities versus cancer tissue. And so by controlling the pulses, we're actually able to deliver more destruction to the tissues nearby and preserve some of that architecture of the vessels and the essential structures that these organs need to function. Next slide, please. And so what the other interesting component in my mind and what separates us from other ablative technologies is because if you can imagine, there's microwave ablation, thermal ablation, and in the essence, the ultimate ablation, which is cutting, excising tissue or a wide local excision, is two different features. One is the ability for histotripsy, in essence, to amplify immune response. And as everyone knows, there's a wide breadth of utilization of immune therapy across different cancer sites. But in general, approximately about 1 in 3 patients really in a non-selected population really derive a great benefit from immune therapy. And we're looking at ways of turning immune cold tumors into immune hot tumors, or to train our body to be able to utilize the immune therapy to kind of attack these tumors. And what this study showed in mice here on the left is actually that histotripsy really amplifies and generates a large CD8 T cell response when there's a treated, and also generates an abscopal response in non-treated tissue. In essence, the biological rationale to this is, while radiation induces most cells to undergo apoptosis, kind of in a cold immune response, by rupturing these cell membranes, there's a lot of antigenetic release of intracellular material, in essence driving a lot of inflammation and potentially driving a greater immune response for these types of tumors. The second, as another pivot, is the ability for this treatment to potentially clear vessels and nerves that could be very difficult to resect for doctors like Dr. Pimiento or some of our pancreatic surgeons. And at the bottom, what you see is a locally advanced pancreatic tumor, which is involving the duodenum on the left side of the picture, which is normally not an issue for a surgeon because some of the small bowel comes out with the tumor. But on the right side, you can actually see encasement of a blood vessel, which is essential for the patient to continue living. And a concept where this technology could be applied would be to clear these blood vessels in a manner that would be much more effective than a radiation technique would be, to potentially enable a curative surgery for a patient that has a localized tumor. Next slide, please. And so what I'm hoping to pioneer or push forward here at Moffitt, and we obviously have a great investment in Spiritus, Florida, is a cooperative group between histotripsy and Moffitt. And this is not just exclusive or unique to esophageal cancer. There's extensive applications for this in many different disease sites, including breast cancer, prostate cancer, sarcoma, and renal cell carcinoma. But I think also another important concept is that there's great value in this technology, as it's only 10% of the cost of our Cadillac ViewRay radiation machine. There is FDA approval that is coming this year for liver treatments, and as I said, this is a novel technology. There's a lot of testing to do, and I think Moffitt's in an excellent place to kind of pioneer this. But also importantly, there's feasibility financially, as they do have a CPT code that's going to be able to be billable as well for this treatment. And so, while it's not just localized for patients with certain types of cancer, I think Moffitt's a great location for us to kind of amplify this technology.
All right. Well, thank you so much for that, Dr. Palm. So now I'd like to introduce my another colleague, Dr. Shaffer Mok. Dr. Mok is an assistant member in the Department of Gastrointestinal Oncology. He's a gastroenterologist with special training in advanced endoscopy. His research interests include endoscopic ultrasound-guided therapeutics, as well as adjunct or alternative therapy for gastrointestinal cancers, and optimizing endoscopic tissue acquisition. Please take it away, Dr. Mok.
Thank you so much for that kind introduction, Dr. Mehta. I wanted to thank the panelists for volunteering their time this evening. And I wanted to thank all of you for giving up your dinners to listen to a wonderful topic, which is so near and dear to my heart. So I'm Dr. Shaffer Mok. I'm a therapeutic endoscopist. That's a fancy type of GI doctor that diagnoses, treats, and removes GI cancers in their early phases. I'm also boarded in functional medicine, so I perhaps look at things just slightly different than other therapeutic endoscopists do, because I'm always thinking about nutrition, mindfulness and meditation, and movement. Here are my disclosures. Next slide. So what I'm going to focus a lot of the discussion on today is what we call third space endoscopy, and a subset of third space endoscopy is called ESD. Third space endoscopy is a relative alphabet soup of terms. Some of you that have had a colonoscopy may be familiar with the term EMR, which is basically similar to ESD, but we're just removing things using a snare or a lasso device, which is commonly used for removing polyps. But since the 1990s in Japan, there is a newer technique called ESD, where we're able to actually remove early GI cancers and lesions that are more superficial in the GI tract endoscopically. What this means is that, using a flexible endoscope while the patient is sedated, and this scope is about the size of your finger, we can introduce this into the mouth, and we can operate into areas such as the esophagus and the stomach. I don't want to exclude the lower GI tract, but just for the purposes of today's discussion, we're going to talk about the upper GI tract. The basic steps behind ESD or endoscopic submucosal dissection involve first a really detailed inspection of the lesion. There are a lot of things with lesions and the way that they appear, and I'm going to show you a video in a little bit that can tell us actually how deep within the wall these tumors may be. And so taking a detailed inspection is really important. As Dr. Mehta mentioned, I also do something called EUS, again, another alphabet soup, but we introduce an ultrasound probe. And I always use the sandwich analogy. I know some familiar faces have heard me explain this in the attendee list there, but you think of the esophagus kind of like a sandwich. And so this ultrasound introduced into the esophagus allows us to see how deep within the wall of the esophagus a tumor may be, and whether or not it's feasible to potentially remove that tumor endoscopically. And so here are the steps after we've made that assessment and determined that something is kind of high up in that in that esophagus. We take the lesion and we inject the meat and cheese part of that sandwich with a blue cushion of water. We use a blue dye because that allows us to identify the space easily. It highlights blood vessels that we may encounter in that space, and it also tells us a margin of safety. And adding that cushion gives us a space to actually introduce the scope into, and we operate within that middle wall or the third space of the organ in question. We then mark the lesion on the outside, and then we make an incision using a tiny little knife that's probably about the size of a pin. And we make an incision around that lesion. We go into that blue space, slowly dissect the lesion, and then we're able to remove the lesion almost always in one piece. Next slide. So according to the Japanese Society for GI Endoscopy, these are the indications for endoscopic resection. Now, I don't want to bore you with all the details here, but you'll notice that the green areas, majority of them have an M letter next to them, and that is lesions that exist in that top layer of bread. But you'll notice that there are a few exceptions here where we can extend our indications down into that meat and cheese portion, namely the colon. These percentages that you're seeing listed are the risk of lymph node involvement, as opposed to what Dr. Pimiento is able to accomplish. When we're doing these procedures, we're just removing the tumor itself, and we don't remove lymph nodes with the tumor. And as such, if you're doing a removal in something that's too deep, well, then there is a risk of the lymph nodes being involved over time. As far as the esophagus goes, we treat esophageal adenocarcinoma, meaning coming from glands, very differently from squamous cell carcinoma. And you can see that the depth of these different types of cancer really does impact the risk of lymph node involvement. Next slide. These recommendations are not just in Japan, these are also in America in the NCCN guidelines. The NCCN guidelines are actually a little more liberalized and with their indication for endoscopic resection. And a lot of this is based upon probably the more recent data than the last iteration of the JGS guidelines. You know, we're lucky here in America to now have ESD. It's actually taken until about the last 10 years to make it over here. And that's largely due to just advancements in technology. I remember working with a doctor at Hopkins as a medical student, and he was one of the early pioneers of endoscopic removal. But it really hasn't been until recently where we're able to use the technology to kind of drive the benefits of this procedure. Next slide. So here's a video of an ESD, and potentially one of you out there or another patient of mine in a former life back in Cleveland. You can hit the play button if you would like. And I'm going to walk through what you're seeing in this endoscopic view. Essentially is about a 8 to 9 millimeter width. So everything looks really big, and you may see some bleeding periodically, but keep that in mind that everything is magnified. So here's a tumor located at the very end of the esophagus. The esophagus is essentially a long tube, right? The job of the esophagus is to deliver food from point A to point B. I always say it's the least pretentious organ in the human body. We're making the marks around the outside with this little tiny knife, again, the size of the point of the pin. We inject that blue cushion of water to inflate the esophagus up. And then you see now I'm using this knife to make an incision around the edges and kind of create a pocket that I can work in. You're actually able to see the layers here within the esophageal walls, and those little fibers are that M3 portion that we're talking about. Now I'm going into the stomach, so I'm making we call it the anal end of the incision, so the very distal end, the one that's farthest away from the mouth, and then we connect these two on the side. And, you know, one thing to note is when you look at esophageal tissue under microscopes, electron microscopy, so little tiny microscopes, there exists actually a lot of blood vessels within this top layer. And so micrometers or millimeters of the depth at which you put this knife is very important. You can encounter blood vessels if you don't go deep enough. But if you go too deep, you may cause a tear in the esophagus. And that's obviously a worse problem to have for the patient. Here we are existing this kind of spider webby space. This is called the submucosa. That's the meat and cheese that I was talking about. And it's in this meat and cheese area that a lot of blood vessels exist that we can encounter. And we can actually use this same knife to cauterize those blood vessels in real time, somewhat similar to what Dr. Pimiento does in the operating room. You know, the main thing that can obscure your view during this is bleeding. And so we just are very methodical and calm about controlling these sorts of things. Here you go. We're starting to end and finish this resection. So you can see that last few threads of the submucosa, and there the lesion's free. Here I'm backing up. You can see the very end, and this is the margin, that area of the meat and cheese that's exposed, kind of the bottom layer, almost onto the bread. And there's the specimen outside of the human being. We then take that specimen, we ink the deep margin, similar to what surgeons do, to allow us to determine how deep within the wall it is. And this is very valuable for staging purposes. You can go, I guess that's it for slides, right? But, okay, so here is our Moffett Experience. You'll note to the right how, on average, standard ESD does in terms of, you know, putting the clinical research together. And to the left is our Moffett Experience. We have since expanded this, since I've updated these slides almost a week ago, and we've done several of these. So our end block resection, which means getting the specimen out in one piece, is better than the international averages. Our ability to get that out and have negative margins is also superior by about 20% as compared to what the averages are. And not only that, but, you know, the most important thing is that we get you and your family members out that same day. You know, I think that that's the main difference between surgery, and this is the recovery time, right? Most of these patients that undergo these procedures are able to leave the same day on a very strict regimen of medications and diet, as opposed to having a longer stay. And obviously, we preserve your organ. We leave the esophagus, the stomach, or the colon intact. We do this very safely as well. So our bleeding risk overall is similar to international and national averages. And of all of the patients that we've had who have had bleeding, none of them have had to require a transfusion or any sort of endoscopic intervention to stop an area of bleeding. We also have had no perforations, knock wood. I feel lucky to have not made any holes in the esophagus. And one of the other risks is that some people can develop a narrowing in the esophagus or overhealing. That has happened to one of the patients in this group, again, lower than the national average. So thank you all again for your time. You know, I'm so excited to be bringing this to the Tampa Bay area. There appears to be such a need, and I feel lucky to be serving all of you and some of you in the future.
Thank you so much, Dr. Mok. So after all these presentations, I would like to take a moment to introduce one of our partners here at Moffitt. That's David Curry. David is with the Moffitt Foundation, and he partners with the Gastrointestinal Program to ensure that we receive the research dollars we need to get clinical research off the ground and make advances in cancer treatments. And if you'd like to learn more about how you can help, please do contact David to find out more. David, would you like to say a few words?
Yes, thank you, Dr. Mehta. Just a quick reminder to everybody, we are going to have the Q&A here in just a moment. And if your question does not get answered this evening, no worries, we'll follow up with you and with the experts, and we'll make sure that we get you those answers to your questions. As Dr. Mach had mentioned, it's you're giving your time tonight, and there's so many things you could be doing, but you chose to join us this evening. So I hope that so far it's been beneficial. And again, if you have questions that you'd like to have answered, that will happen very soon. One of the great things about working with this group is these are all experts, whether they're in the clinic or in doing their research, and they are not just helping patients locally, but the impact of their work is actually has an international reach. And so the things that you're hearing about tonight are going to help people all around the world. So you can see that we're right at the forefront of all of these new technologies and all of these new techniques. Many times, as I'm speaking with patients and their family members, the question comes up: how can I help? I want to give back. There's something that I want to do to help. And so if you're interested in exploring ways that you can support this really important work that's happening in the GI program, I just ask that you consider that, and then contact me at your convenience, and we'll look at some ways that you can help this group. So thanks again for joining us tonight, and we're going to get to one of the most popular parts of our webinars, and that's the Q&A. So Dr. Mehta, I'll turn it back over to you and the team.
Thank you, David. And we all truly appreciate all that philanthropy does to make research possible. So now we would like to invite you all to ask any questions that you may have from our speakers tonight. And you may write your questions in the Q&A box. I think we had already started answering a couple of them. However, I will try to read out some of those here. Give me 1 second. I'll try to go to some of the questions that we already answered for the sake of some other people in the audience. I think one of the first questions that we had was, can histotripsy, it's going to be a tongue twister for me, be used in tandem with chemotherapy for metastatic cancers? Dr. Palm, would you like to allude on a little bit of your answer?
Yeah, so while there's only some preclinical data in this space, my understanding is that this can be used in a multitude of different settings. Although what I will say is, out of an abundance of caution, we commonly don't give high-dose chemotherapy in combination with other ablative therapies, specifically radiation. But in certain patients, we will discuss that to synchronize treatments to give chemotherapy at the same time as an ablative treatment like histotripsy. But I can't speak specifically to that setting.
Okay.
And it's important also to remember that right now we're trying to learn how effective could be histotripsy for the management of different cancers. So we're still in the clinical trial phase for different cancers to figure out and understand what is exactly the role. This is very exciting technology. This is really, we're looking forward to see how much can impact patients. But right now is not what is used in the standard for management of patients.
Okay. We have maybe a comment, and I might guess a question in that comment, but we have somebody in the audience who has been a stage 4 rectal cancer survivor and has had surgeries, developed adhesions due to surgeries, and caused a lot of bowel issues, causing pressure, tightness, bloating. Dr. Pimiento, Dr. Palm, any thoughts on, is there any form of management that could help this person with the symptoms that they're experiencing?
So I think this could be a common problem. This could be many reasons why the symptoms can appear. I think what I would advise is to be sure that they contact their original treatment team and they're able to discuss the symptoms with them. Some things could be expected, some things are not expected and therefore will require management. But usually, if you start asking enough people around different questions, somebody's going to end up giving you probably wrong information. So it's a good idea to start with your primary care team. And if you actually are having too much problems, visiting with a surgeon and having an actual evaluation of your case, imaging results and all that would be necessary. Anything that we can tell you just by hearing some of the couple of the details of what happening in the care is not going to serve you well. This requires a lot more in-depth evaluation.
Thank you. I think the next question was, are smoked foods healthy? And I kind of put a link in the chat, which kind of alludes to actually one of the Moffitt talks, which said that in general, smoked foods are not healthy. They do increase cancer risk. So that's kind of the short answer. And then I think the next question was, why is esophageal?
We can agree that they are delicious. But the fact that they are delicious doesn't have to do much with health. And yeah, please review the information. There is clear data in some of these processed foods, what they come with. That is part of the reasons why we're seeing so much gastroesophageal cancers in the US, because our diets and our food intake is not amazing, or at least could be a lot better. But we agree with you, it's delicious. So we try to stay away from it.
I think another question, which we can all speculate, but may not have an accurate answer, is why is esophageal cancer more prevalent in men? And again, there are some genomic factors, some hormonal factors that can play a role. But yes, it's something that we all know of, but there is not a clear-cut reason why it's much more prevalent in men. But I wanted to see if there were any other thoughts from my colleagues. Yes, no.
So I can tell you that some of the risk factors are all risk factors associated with other diseases that are more commonly seen in men: obesity, heart disease, the metabolic syndrome. So there may be a hormonal protective effect, but in general, these diseases, at least the adenocarcinoma of the esophagus, that is not necessarily related with smoking and drinking, as much as the squamous cell, although if you are a smoker and a drinker and obese and have reflux, then you're to get adenocarcinoma. But what is clear is that similar factors that are associated with heart disease long-term or other diabetes, other diseases that are, again, bad for your overall survival, are the same risk factors for adenocarcinoma of the esophagus. Therefore, it may be an association between what women do, or it may be truly some protective effect from estrogen. But in general, ladies are a lot smarter than we are. So I think we can also blame it on that.
All right. I think next one is, I think, a great question asked by someone in the audience. What advice would you give someone with a new diagnosis of esophageal cancer? And I think we all, coming from different specialties, will have our own spiel, but maybe Dr. Pimiento, because you're kind of usually the first person that sees these patients.
Actually, let's have Dr. Mok. He's the front line.
That's true. He gets to diagnose them.
He'll talk about the sandwich and he'll talk about the this. So he has it all figured out. So let's hear him.
Let's hear it from Dr. Mok then.
But yeah, he's
sure. Yeah. I think prioritize protein is the thing that I talk to my patients the most about. You know, your nutrition going into a surgery, a chemotherapy, or radiation, an endoscopic procedure will help you to have a better outcome, as Dr. Pimiento talked about. And so I do a lot of time counseling patients, on nutrition. And the reality of this condition is that sometimes you physically cannot get nutrition into your body, right? So asking your healthcare providers to assist you in that. And one thing about protein, I'll say, is that it is easy to get into your body in solid forms, liquid forms, and everything in between. And so, getting that supplement from wherever it is that you buy your healthy sort of foods, fruits and vegetables, you can always turn something into a smoothie and get it into your body. So prioritize protein is one of the first things that I talk about.
Thank you so much.
So let me take so the first so I get to see people after they have had their endoscopy and they get that. And I think number 1, number 2, and number 3 is staging. So we need to be sure that once you have a diagnosis of esophageal cancer, the priority is not to start treatment tomorrow. The priority is not to do surgery the day after. The priority is to know exactly what we're dealing with. That means having a good pathologic evaluation of the specimen. So whatever sample you had, see if there is any special marker that make treatment for that type of cancer different. Number 2 and number 3 will be to actually perform CAT scans and PET scans because sadly about 42% of people may present with metastatic disease. And we just need to be sure that before we start therapies, we know we are dealing with either local disease, local regional disease, or metastatic disease. And it's important to have a treatment team that understands this. It's not just reading a CAT scan report. It's not just getting somebody telling you in a note everything is fine. It's actually reviewing the scans with you. It's actually be sure that the provider takes a look at the scans and they see what is going on, because it's very easy to miss very big things. We are lucky that we have a gastrointestinal upper GI tumor board. This is a tumor board where we have radiologists, medical oncologists, all the people that you see here and more, actually seeing the testing of the people, seeing the CAT scans, PET scans, pathology, and trying to come with a comprehensive plan. So the next step, once you have a clear diagnosis, clear stage, everybody's told, oh, you have a early stage cancer before they even get a CAT scan. And again, you cannot assert that before you actually get complete imaging staging. Once you have that, then it's good to go to places where people understand cancer care and understand how to better deal with these very complex treatment strategies. So I would, again, the advice will be first, not rush. Doesn't mean that you're going to wait and it's going to go magically away, because it never happens. Like it is what it is, but you just need to clearly understand what stage we're dealing with, what is the best strategy based on the stage, as that picture that I show you guys. You can go and say, okay, so best strategies are this, and that. Sometimes patients get really anxious, and then we want to have surgery tomorrow or the day after tomorrow. And that is where you hear it was stuck to this or it was stuck to that, when all those things are clearly able to be evaluated on an imaging study. So I think priority is too good for a reputable place to get cancer care, to complete the staging, and always is better to just slow the car down to be able to see exactly what we're dealing with, and then formulate a plan that has better chance to be successful. The idea is not to rush to it. The idea is to go farther.
Perfect. I think there was another question on a very similar notation, which asked about, terms of diet to maintain nutrition. So I think we've kind of touched upon that. There are some other questions. I think a lot of them in the audience are curious to know about Dr. Mok's nutrition and meditation recommendations, and if there are these formal recommendations, are they available anywhere for patients to review?
Yeah, I actually have a podcast that all of you can listen to right now on whatever streaming service you like. It's called Maximal Being. I host this with a friend of mine who is not medical, so he keeps me from being less nerdy slightly and keeping things into terms that people can digest. But anybody that's interested in meeting with me to talk about the role of functional medicine in cancer care, I am available for consultation at Moffitt Cancer Center. So come and find me, and I'd be happy to share all of my thoughts.
All right. Thanks so much, Dr. Mok. And I think there's a question here which I'm trying to understand, but CA 19.9 increase with severe abdominal intermittent paralysis, meaning of malignancy, narrowing of the esophagus and polyps on stomach, are they related? Can stromal sarcoma or GI sarcomas be seen by simple polypectomy? I think I'll pose this question to you, Dr. Mok. Is there a way you can say, looking endoscopically on a polyp, whether that has sarcoma component versus a polyp that can lead to adenocarcinomas?
So the answer is yeah. Most of the time we can. We're very lucky, again, at Moffitt to have cutting edge technology. We have very high level scopes using high definition. These scopes can magnify up to about 100 times that of what you're seeing in the video. And we can utilize something called narrow band imaging, wherein we're able to select all the colors of the rainbow out with the exception of blue and red. And so that allows us to really look at the architecture of the tissue well. And once you get trained and are able to evaluate these lesions, it is very good at predicting the depth of invasion. And I'd say as a second adjunct to that, that endoscopic ultrasound that we use to determine how deep within the sandwich it is also pretty good at that as well.
All right.
But the determination of the type of cancer it is a determination that is done by the pathologist. So
Right.
things look similar, and some tumors may look similar. Some of them may have characteristics that are clear on a CAT scan or a PET scan, and you can say, okay, this looks like a stromal tumor. This looks because it's submucosal, and we think is that. But in general, we really rely heavily on the pathologist to tell us the cancer it is. We say there are truths, and there is pathology. They are the ones who actually have the tissue, and they can tell us, oh yeah, it's out, it's not out, it's this or that. And some other times you're surprised. We just put money and say, man, this has to be this. And then it comes out, and then we say, oh no, it wasn't. So really the pathologists will help us, and we have excellent pathologists that give us really good information.
Great. So I think there are a couple of questions, I think all kind of highlighting towards work that Dr. Mach is doing. They're all interested to know how they could qualify for the endoscopic procedures that you offer. They're kind of interested to know how to address some bowel issues, digestive problems, especially prior to surgery if they were to have any. I think there's also interest from a duodenal neuroendocrine cancer patient about again your adjunct therapies. So I think we would probably will have our foundation members kind of help these patients direct to Dr. Mach, so he could hopefully kind of lead the way and help them in their cancer journey. I will turn on to maybe Dr. Palm. Are there any recommendations with terms of radiation, especially the emerging radiation techniques for treatment of abdominal adhesions?
Yeah, that's a great question. So unfortunately, radiation is generally pro-inflammatory, and radiation may actually worsen abdominal adhesions. To my knowledge, some of the best treatments that we have would probably be a surgical intervention. But my recommendation just for symptomatic management, and Dr. Mach could probably, with his expertise, weigh in as well, is ingesting foods that probably have a low likelihood of gas generation and starting on probiotics. And it sounds like constipation may be a factor in worsening those adhesions as well. And so I would also consider looking at stool softeners and kind of, high fiber diet. And I'm not sure if Dr. Mach, if that's something you agree with, or if you have any other additional information to that.
Yeah, I have a lot of thoughts about it. The main way that gas is generated in the GI tract is several fold. So obviously taking in things that have gas will lead to gas being trapped within the GI tract. Also eating or drinking too quickly. And often we do this subconsciously, right? You're watching television and you're eating while watching television. While we eat very quickly, we're ingesting a lot of air. And so practicing mindful eating is very important to reducing these bloating symptoms. But when somebody eats a food, usually of any type, or in particular, when they tell me that they've eaten something that is vegetal and developed gas afterwards, what I think is dysbiosis. And so many of you probably have seen things about gut health, microbiome on Instagram, etc. There's a lot of good science behind this. And we know that these trillions of bacteria, yeast, parasites that live inside of us interact with our food in good ways and bad ways. And when you eat the standard American diet, or the SAD diet, we call it in the functional medicine world, it can interact very poorly with your microbiome and get things angry. So it's just like planting a garden. If you have weeds in the garden, you have to weed the garden, you got to till the soil, then you have to plant your new seeds, and then you have to give them nutrition. So rather than giving probiotics right away, which will make you feel worse, we like to get rid of the bad guys, either through some selection pressure, medical, herbal, etc., diet, and then introduce the good guys in the end.
All right. I think we will take the last question here, and I'm sorry, there are many more questions in the Q&A. We won't be able to get to all of them today, but as I mentioned, there there are team members here that are noting down every question, and we'll get back to you with the answers. But the last question that I'll probably take this upon myself. What newer immunotherapies and chemotherapies are available for squamous cell carcinoma, and when are they used? So I think that's an evolving answer, so to speak. In the locally advanced setting where the cancer hasn't spread, we have, historically relied on chemo with radiation. When that may change in the future, we have some great clinical trials ongoing looking at the combination of immunotherapy with chemoradiation, but there's no data out there, so that's still pending. Patients who've had chemoradiation have undergone surgery, and there were still live cancer cells at the time of surgery. We are now offering them immunotherapy for about a year. And then moving on to somebody who is having stage 4 cancer or incurable cancer, we're now offering them chemo with immunotherapy in combination, or 2 immunotherapy drugs, depending on the patient profile. But that's kind of the long and short answer. I would say there's a lot more that goes into that decision-making process. As I mentioned, this would have been the last question that we could answer. Unfortunately, we're short of time. It was great to see so many thoughtful questions that came up tonight, and we'll definitely try to address each one of them. And we truly appreciate all your continued support as we work to revolutionize cancer care and bring some best possible outcomes for our patients. Thank you all.